When doing the consultation and surgical planning for the hair transplant patient, we need to evaluate for the four things very important. Number one is the medical history, in which we have to see that this is androgenic alopecia, there is miniaturization, this is not telogen effluvium, there are no other deficiencies, and this is a confirmed case of androgenic alopecia that needs to be recovered by the hair transplant. The second thing is medical history. In the medical history, the medications that the patient is using, especially sympathomimetics, non-selective beta blockers, tricyclic antidepressants, that if the patient is using that, we have to substitute it because it has an adverse reaction with the local anesthesia that we give, epinephrine and lidocaine. The second thing that is most important is that the other, like diabetes and alcohol use, tobacco use, history of seizures, this need to be seen in the history part, medical history part. The second thing that is most important is the physical examination, like DUPA, diffuse unpatterned alopecia, in which there is more than 20% miniaturization in the donor area also. So in that case, that is an absolute contraindication for the hair transplant. So in the physical evaluation, there we need to evaluate by the dermoscopy that this is not any other condition than androgenic alopecia, or there is not the scarring alopecia. This case is suitable for hair transplant. So physical examination is very important. The third thing is that we need to do the surgical evaluation, that can we cover all the area with the available donor area or with the beard area. Like if a patient needs 7,000, 8,000 or 9,000 grafts and his expectations are very high, and his donor area we cannot take more than 2,000 or 3,000 grafts, then the hair transplant will not be of any benefit. So the third thing is in the physical examination and the surgical evaluation, we need to see about that how much number of the grafts we can take, and then we need to see about the surgical things, like we cannot make the temporals in the very young. The crown in the very young is absolutely contraindicated. We need to see about the history of keloids, that there should not be the history, there should not be the use of the antiplatelet drugs. So the examination and evaluation is all the important things that we need to notice, have to be written and have to be properly planned, and then we need to go. Either it's a minor surgery, but it must need to be done by a properly trained environment.